Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody. Good evening, good afternoon, and good morning, wherever you are. And you are most welcome to this very distinguished session in the Cornea series of Sinjab Academy Club. First of all, I would like to thank Prof. Soosan Jacob for everything. Second, I thought a lot of how to introduce Soosan to everybody, but I found that she doesn't need to be introduced. Nobody doesn't know Soosan. She is one of the global figures in corneal surgery who have changed the way of thinking and approach. Her CV and life are full of impressive achievements and great contributions to the field of ophthalmology and corneal specialty, in addition to the international awards and recognitions that she received for her research, new surgical techniques, and much more. So I thought it would be much better to take the time to thank her so much for devoting some of her precious time to teach us on the platform of Sinjab Academy. Thank you very much, Soosan, for joining us today and for teaching us. And I'd like to thank, of course, Dr. Hussam for being with us as a panelist. And there will be 2 to 3 other colleagues who will join us as panelists later. And thank you again, Soosan, and the stage is yours. We cannot hear you, Soosan, we cannot hear you.
Sorry about that. Thank you so much, Professor Sinjab, Professor Ziada, and I think Professor Tarek Tamish was also instrumental in sending me this invitation. Thank you so much for having called me here for this wonderful Sinjab Academy, which really has been instrumental in teaching so many ophthalmologists so much. Absolutely, topography is, I think, synonymous with Professor Sinjab's name now, and it's really an honor for me to be able to come and present here. So I'm going to just share my screen now, and the talk is on corneal allogenic intrastromal ring segments, or CAIRS. And basically, as I just said, CAIRS stands for corneal allogenic intrastromal ring segments. And at the beginning, let me say that I do have a patent pending for special Trifines devices and processes used to create these. And in fact, I've just received news that my patent has been allowed in the US. So we know that the current treatment of keratoconus is basically cross-linking plays a huge role in it. But despite playing a huge role, it really also has in one way a limited role, because regularization of corneal topography or improving of vision is not that much contributed by cross-linking. And so even though it does play a huge role in limiting progression or stopping progression, patients are often unhappy with isolated cross-linking alone. And this is because these patients have huge amounts of irregular astigmatism, and because of that, decrease in vision, and this is not treated by cross-linking. And so very often, as Professor Sinjab just said, we have been treating these patients also by implanting intracorneal ring segments, or ICRS, and there are various commercially available ICRS, which include Intacs, Kera rings, Ferrara rings, and so on. But one thing common with all these artificial segments is that they're made of PMMA or plastic. And though they're effective in improving the quality of vision, they can sometimes cause problems. For example, these are all from my own series, where you can see the migration of the rings, one lying on top of each other, extrusion, again extrusion of Kera rings, and need to explant them, infectious keratitis, even requiring therapeutic penetrating keratoplasty, and so on. So this image is courtesy Dr. Gillian Su from Hong Kong, where she shows this case of intrusion where the one end of the Intacs, which was originally well placed, has intruded into the anterior chamber. And we've also got case reports which describe acute corneal hydrops post intrusion of the Intact segment, or the Kera rings, or the basically, or the I should say synthetic ICRS into the anterior chamber. And here's also one case from my own series where the right eye I had implanted Kera rings, and we had to explant one of them because of extrusion, anterior extrusion, and in the left eye we had implanted Intacs. And you can see just recently she came back about maybe 10 to 12 years later, and she's got this intrusion into the anterior chamber. You can see this extremely thinned out posterior cornea, almost not there in this particular axis where the scan has been taken, and also causing some amount of opacity over there, and really with us wondering whether it's going to lead on to an acute hydrop very soon. So I had this idea in about 2015 about using allogenic implants, just basically because I wanted to get rid of the use of synthetic substances within the cornea. And we published our first series in Journal of Refractive Surgery. And as I said, the acronym stands for Corneal Allogenic Intrastromal Ring Segments. And though in this talk, I'll be showing a lot of donor corneoscleral rims, please do remember that this acronym, when it was coined by me, was made to stand for any source of allogenic tissue, which could include fresh donor stroma, preserved donor stroma, processed stroma, or basically any other source of allogenic tissue. So this is the double-bladed trephine with which I am able to make these. I'm sorry, make these rings, and this is a patent pending, and in fact, it's just been allowed. So here is the two blades that you see, which are concentric to each other, which gives you this rim of donor stroma. And just to show you in a little more detail, when we're using a corneoscleral rim, what I do is first remove the epithelium, then remove the endothelium. Those are the two concentric blades which are there, which are placed centered on the rim. And so you get an inner ring of cornea which is removed, and the ring of stroma basically is then cut into a size whatever you want, the arc length, and then it is implanted into femtosecond laser dissected channels within the keratoconic patient's eye. So since this is lying intrastromally, it changes the topography of the patient, and therefore you can use it using different nomograms, etc., to kind of get the best possible results for the patient. In progressive cases, you can combine it with cross-linking, either simultaneous or sequential, depending on your preference. Here is just yet another video where, again, I show the epithelium and endothelium being removed and the trephine being placed. These trephines are available in different sizes, so you can alter the amount of corneal tissue that is being placed into the cornea. Here, I've also taken this segment of corneal tissue, and you can actually split it further into two. So you can get various different sizes right from the trephine itself. And also, if you want further sizes, by splitting the graph that you have into further sections, and really it is not very difficult to just hold it there and draw the knife down so that you can get different sizes of tissues. Again, the femtosecond laser dissected channel, which is being opened up by the glide dissector, and the segment is being implanted in. You could stain these segments with riboflavin and then implant, or as my good friend Jack Parker does, you could stain it with trypan blue and implant, or as he and Shady Awad, two other very good friends, do. You could dehydrate this and implant. So various different, now that it's being done in multiple countries around the world, different modifications which are being now introduced to make implantation easy. But as you can see, implantation is pretty easy. You can just push it in, and then this was in the beginning when we used to trim it to size after putting it in, but you'll see my latest technique where we have kind of made it more predictable. This is manual CAIRS for those places where the femtosecond laser is not available. Dr. Hussam, as those of you who were there live just some time back, had promised me and has actually got this instrument made for me, but unfortunately not been able to get it to me as yet. But this is something that then from his brilliant idea of getting this manual dissector, and just because the pandemic was making it so difficult for me to get access to his lovely gift, I had to get this made. And I'm not sure whether it's exactly what Dr. Hussam has, but something just maybe possibly a little similar I've tried to make. And this is gives you a manual dissection of the channel, into which then you can place the CAIRS tissue. And of course, other than this, you also have the prolate cornea system, which is a suction-based apparatus, which is available from AJL Ophthalmics, and that can also be used to create these manual channels into which the CAIRS segments can then be placed. So here are some post-ops, and here you can see mid-stromal depth, the slit image of the cornea. And you can see these intacts, these CAIRS segments placed much more superficial than intact segments. Intacts, as you know, or other synthetic segments go at about 80% depth with a lot of stroma kept above it in order to prevent extrusion. Here, that is not the case with CAIRS. You can really put it at 50% of the stromal depth. 50% of air. You can even place it more superficial, but I prefer to put it at about 50% of stromal depth, because then it gives you a very good effect. In fact, much more than intacts also could give. And I'll show you some examples of where they've removed intacts and replaced it with CAIRS and got lovely results. Again, some more examples. These are cases where we've enlarged the optic zone and gone more peripherally. Here you've got about an optic zone of probably about 6 millimeters. You can go even closer. You can have 360-degree segments implanted intrastromally, or you could have two segments which are implanted on either side of the incisions. This is again showing you the mid-stromal depth, the slit image And these are anti-segment OCT images showing very well placed quiet segments seen. These are light microscopic images of the segments of the CAIRS segments, which show very parallel, longitudinally oriented, and very quiet looking lamellae, which are seen on light microscopy. What are the disadvantages of synthetic implants which we are actually trying to overcome with CAS? We know that synthetic implants don't just have the complications that I showed just now, which includes thinning, necrosis, melt, and so on, but also the fact that synthetic segments cannot be implanted in very thin corneas, which are less than 400 to 450 microns in the zone of implantation, or very steep corneas, generally 58 diopters being taken as the upper limit for the steepness of cornea. So this means that if you've got a patient who's a reasonably advanced case, he is not able to have a synthetic segment implanted just because the risk of complications increases much higher. And so these patients who really need a lot of improvement in their visual acuity are deprived of the ability to have an improved visual acuity secondary to placement of ICRS. And in these patients, you can definitely place CAIRS because it's allogenic, so it's completely biocompatible. It remains there and gets integrated with the host cornea. And all of us being corneal surgeons, we've got years and years of experience with placing cornea on the descemet and predescemet membrane as in DALC, or within the antechamber as in DSEC, PREC, etc. And so we're very comfortable using cornea, and we also have a long history of safety using cornea, allogenic sources of cornea. The other disadvantage of synthetic segment, as I said, is deep implantation and leading to limited effect, whereas here you can go superficial, getting much better effect. This is a chapter which I contributed in YANAF on CAIRS, and here you can see the intacts being placed very deep, whereas you can see the much more superficial placement of CAIRS, and also you can see the clinical image comparison between the two. You also have to have FDA approval for different thicknesses and different arc lengths when you are manufacturing synthetic segments, whereas the CAIRS is completely customizable by the surgeon himself. So you don't have to have large inventories in your hospital. You don't have to have FDA approvals for different types of different arc lengths and so on. So it's really much more easy to do this surgery. As I said, because it's biocompatible and biointegrable, CAIRS avoids complications. You can implant it in thinner and steeper corneas. That means much more advanced cases. But it's not just in those advanced cases, but also in very mild and early cases, as I'll show you, that you can implant CAIRS, and you can get more effect because it's superficial. And also you can put arc segments almost up to 360 degrees with CAIRS. The other advantages that it has is that you don't have glare and halos like you do with synthetic segments, so you can use much smaller optic zones. Again, you can get greater effect just because you're using smaller optic zones. There's no effect of continuing eye rubbing by the patient, which could result in the cornea thinning out over time and thereby result in erosion, even if the intact was initially well placed. Whereas with CAIRS, the effect of continuing eye rubbing is not going to cause, it may cause progression, of course, but it's not really going to result in, conditions where the CAIRS extrudes and thereby causes problems. There's no fear of intrusion or high drops. It's so much more customizable. As I said, no need for large inventories. It's also reversible and adjustable, and there's no need for long steroid usage. You have good outcomes cosmetically, and again, it does not take away the ability to perform any kind of future surgery, including DALC or anything else, or even topo-guided PRKs or faking in ICLs or any of those surgeries. They're all compatible with CAIRS. Here's an example of advanced case where you can see the Scheimpflug image comparison, the preoperative on above, which shows the steep cornea, and the CAIRS implanted in the postoperative. Both the images have been superimposed on each other with the lens being taken as the anterior surface and coincided. And you can see that the cornea is really flattened out, a very good way to explain to the patient what you're trying to achieve with CAIRS. And here you can see even up to 25 to 30 diopters of flattening got, and the keratometry coming to ranges as almost normal, 47, 41, 44, from range that was going up to 72, 66, and so on and so forth. You can also implant in thinner corneas. This was a patient who had cerebral palsy and had a lot of difficulty in being transported to the hospital, an adult male actually, about maybe 22, 23 years old. And for him, the option would have been DALC, taking into consideration only the 230 microns in this small area of his cornea. But what I did is an epithelial island combined with a CACXL cross-linking, contact lens assisted cross-linking, together with CAIRS, which gave us a good effect. And he's to this day good and very happy in his home. And also the biggest advantage is he does not need the kind of follow-up that you would need for a DALC otherwise, with all the sutures and everything that's involved in DALC. The indications are, of course, keratoconus, other causes of corneal ectasias. You could put it in post-cross-linked keratoconus also, and also as treatment for synthetic segment complications. I'm really happy to say it's not just in India. but in multiple centers in US, Canada, Australia, South Africa, Turkey, Israel, Lebanon, Dominican Republic, Germany, Ireland, France, many other places where CAIRS has already been started and is being done routinely and regularly. As I said, synthetic segment complications. Here you can see the intact melt, which is being treated, which has been treated with CAIRS. So the intact was explanted and CAIRS was inserted into this original tunnel. And you can see this patient with the CAIRS on one side and an intact on the other side. So this is really a simple surgery. If you come across a patient, a similar patient who's got a post-intact melt, what you can do is just simply, pull out the intacts, as you'll see here. You can just go ahead and pull it out. And then you can place the CAIRS over the area of defect, measure out how much you need to implant, and then you insert it into that same tunnel from which you remove the intacts, put some bridging sutures so that the CAIRS doesn't pop out and it remains in place. Also put some anchoring sutures on either side, put a bandage contact lens. You could put some fibrin glue at the edges if you want. And basically this is the same patient at just before suture removal and the same patient after suture removal, and you can see beautifully placed intacts. Yet another patient where we've done replacement of a melted intacts with CAIRS, doing very well. You can see actually this is pre-intacts removal and this is post-CAIRS. And you can see that the cornea is actually flattened out even more than the intacts alone had caused flattening. And we have also got now published in GRS with the Shady Award, a series where we've done this basically precisely this procedure. Shady's got a large series of this actually. He's done many more than me as well, where he's explanted CAIRS, explanted intacts and replaced it with CAIRS. So now this is another interesting patient who had intacts put in his eye, and he was not really happy with the amount of visual correction he had. So even though this patient did not have a complication in terms of extrusion or melt, we still, he was keen to try to get the benefit of CAIRS, because now many patients, many youngsters have actually, keratoconic patients have actually heard about CAIRS, read about CAIRS, and they do come asking for this particular surgery. So we said that we could possibly get him a better effect by explanting his CAIRS and maybe putting in explanting his intacts and putting in a CAIRS. So here's the intacts that's just been explanted. It was, I think, about a 6 or 7 year old intacts. I don't remember that exactly, but however, that's been explanted. And now what we do is we make a fresh femtosecond laser assisted tunnel at about 50% depth. The intacts, of course, was at 80% depth. And also the intacts was a 6 millimeter optic zone. So we've gone and created a femtosecond channel with a 4.5 millimeter optic zone for the CAIRS. That's a channel being created. We kept about a 80 to 90 micron gap between the the old intact channel and the fresh CAIRS channel, and we were able to successfully create the new channel. And once we've done that, what I do is open that channel up and then put in the CAIRS segment. We made the entry incision coincide for both of them, and that's the entry incision of the old intacts and the fresh CAIRS channel. And it was really pretty easy to do the surgery. I was thinking that it would be difficult, but actually it really went in very, very smoothly. We had just got to pull the CAIRS into place and everything was over smoothly. And this is basically the topography of the same patient. This was just done very recently by me. This is the pre-operative patient and this is the post-operative topography, I mean. And you can see it's really come to much better levels, 47 and 47 and right from ranges of 54, 59 and 10, 11 diopters of flattening here with the decrease in almost all the parameters, K1, K2, K mean, astigmatism, everything really improved a lot. And the patient really was very happy with this vision, even though it was just the first post-op day. We did combine with cross-linking and there was still some haze that has to still go because this was just done a few days back. Again, another Scheimpflug image showing the flattening of the cornea, the orange being the preoperative, superimposed with the postoperative image, which is the blue. We get beautiful flattening in patients, the right eye and the left eye. And what I want you to notice here is in the right eye, we put thicker segments, and in the left eye, we put thinner segments. And this is because the topography is much less advanced in the left eye, whereas you've got more advanced keratoconus in the right eye. And so by varying the amount of tissue that you put into the patient's eye, you can vary the amount of effect. So here in this case, you've got much more flattening as seen by the shade of blue, darker shade of blue. And here you've got much less flattening, which is what you wanted. Another important and interesting thing I'd like you to notice is that the preoperative steep axis was here, just off 90 degrees. And what we achieved was a post-operative flattening of the the previously steep axis. And not only that, we also got a compensatory steepening of the previously flat axis. So if this was a previously flat axis, we got a compensatory steepening, which leads to an overall regularized cornea. So this is pre-op, this is post-op, and this is a difference map. And what we've achieved is a flattening of the steep axis, a steepening of the flat axis, giving you a much more regularized topography and a centralization of the cone. So this patient actually had a huge drop in the cylinder from -7 cylinder to about -2.5 cylinder, a much better refractive error to have, improvement in the visual acuity from 6/18 to 6/9 or 21/20 to 20/30. And because she had such good results in the right eye, she also opted to go for the left eye, which was much milder. And that's basically the result we got in the left eye. Here's again a very mild case who improved from, who had a -1.5 with the -2.5 cylinder, improving to 6.6. He came to almost plano 6.6 part. And you can see that this eye, the right eye was C3R, I mean, CAIRS with CXL. We got a good improvement. That's the CAIRS segment seen here. And the left eye, which underwent only cross-linking, you can see there was hardly any change in the difference map. And so she came back later the next year to get a CAIRS implanted in the left eye as well. And this is the pre-operative left eye, the post-operative left eye after CAIRS implantation. And we can see that we achieved a flattening in the left eye as well a year later when she came back. Again, a croissant type of keratoconus, which shows flattening and much better topography, improvement in the uncorrected and the best corrected visual acuity, decrease in the spherocylindrical errors, and a much happier patient. You can make different combinations, like a thicker segment on one side and a thinner segment on the other side, or you can change the arc lengths, longer arc length combined with a shorter arc length. If you've got a decentered cone, you could put just one single segment underneath the cone, so that you can flatten that area and also push it up and also get that little compensatory steepening, which gives you a much more regularized topography. So here are other examples of single segment CAIRS. You can see this is a segment and you've got a flattening, post-operatively better picture with about 14 to 15 diopters of flattening varying in different areas. And the interesting thing is that the amount of flattening that you get does vary with the topography as well. Again, different examples of single segment CAIRS. Here's an asymmetric CAIRS where even though the thickness is the same, the arc length is different on either side. Here there's a longer arc length and here there's a shorter arc length used. You can also see the difference in the flattening that's achieved. Improvement in uncorrected from 5/60 to 6/18, and decrease in the spherocylindrical error as well. There are longer CAIRS segments, which is also possible. Improvement again in the topography seen here, the cylindrical errors. And another very interesting thing that I'd like to share with you here is we all know about asymmetric ICRS. A lot of people who've done a great amount of work in them. One of them is my good friend Juan Grandin Carlos, who's using these hockey stick kind of synthetic segments. And you can also do this beautiful technique with the CAIRS, and this is what I call as customized CAIRS. And here customized CAIRS is basically to treat asymmetric forms of keratoconus. So the way that you make the segment is the same. You remove the epithelium, then you remove the endothelium, and you use the double-bladed trephine to punch out the corneal stroma. Once you punch this out, what I do now is I mark the anterior surface or the Bowman side, which is what you have on the towards the top, so that I know which is the Bowman side and which is the endothelial side of this bit of stroma. And once I do that, I cut this into, of course, the desired length. This is now, by now, what I've done is I've designed a good range of instruments that help you do this much more predictably and repeatably. So this is a degree zone marker that I've created for doing the surgery, so that you don't have to put the CAIRS segment in and wonder if that's the correct size that you put in. Instead, what you can do is you can plan according to the topography preoperatively itself, mark on the clock hour and the optic zone that you want, so that you can cut exactly precisely to the correct desired length of the arc length of the segment here. So I've done the arc length, and because it's an asymmetric keratoconus, I'm also customizing it further by changing the thickness along the length of the segment itself. So this segment, this CAIRS segment has different lengths. You can see that it's got a thicker segment, different thicknesses. It's got a thicker area, and then it's got a progressively tapering area, which is thinner. And this is because the topography is also similar, where you want more flattening where the thicker part is going to be inserted and less flattening where the thinner part is going to be inserted. So that's how you can customize it. So again, we've made the femtosecond laser dissected channels, and we have inserted this progressive thickness CAIRS or customized CAIRS into the patient's eye. And you can use this, you can use a Y to push it in and a reverse Sinski to pull it in, pull it further forwards. And the process is, of course, simple. We combine it with cross-linking, and here's the post-operative, where you can see that as the segment thins out, the amount of flattening that you have is also less. You can use this, of course, different lengths. So you can have the tapering over a different length. And the advantage of CARES again over synthetic segments is, in synthetic segments, you have standardized forms of customization, which means that the length of the taper is the same, whatever kind of topography you have. The thickness is the same, whatever kind of topography you have. Whereas here it's extremely customizable. So it's really up to you what kind of customization you want. And you can see in this example, I've really customized it a lot, trying to kind of match to the patient's corneal topography, and accordingly you can change the result that you achieve, which you cannot just do with synthetic segments, because then the amount of inventory of segments that you would have had to have would be just unmanageable. Again, just showing you different examples of customized CARES. I think this we just did. Here you can see the thickness being measured in different areas using the ASOC, and you can see that the thickness is different. Above and below it's more, and in the center it's less. And so we've got a centrally tapered CARES here. And here's again another case with a centrally tapered CARES, and you can see a lesser effect where the taper is, and a greater effect of flattening on either end. Here's an example again. You can see the corneal densitometry showing the centrally tapered CARES very well. This we already spoke about. You can have tapered ends on both sides. You can have a single taper. You can have different lengths of tapers, as I said. So lots of different customizations you can do. And again, anti-segment density, which shows the change in thickness as you go along. You can also have both ends tapered, as seen here. So this is a patient where you can see both the ends are tapered and the center is thick. Here is another example where you can see we've been able to match. This is a pachymetric map in the CSO MS39, where we've been able to match exactly what we had planned for the patient, with a thinner central area and thicker two peripheral segments. So it's really easy to customize this. Again, you can see how we are able to exactly match what we planned in this patient's eye. And as I said, it is really not difficult. So that's a big advantage over Intacs, the amount of customization that you can do. Here's a patient who had very advanced keratoconus. She was almost about 96 diopters, I think, and we were able to bring her down to flattening of about 60 diopters. And we had about 34, 35 diopters of flattening. I have a very good friend, again, Jack Parker, who's been doing lots of CARES in US, and he's also been doing these advanced cases and shared his results, where we have actually been able to do away with DALC in a large number of cases and been able to do just CARES, which is really a big advantage for these young patients. The coma really decreases a lot. Here you can see the coma has decreased from 2.467 to 0.764 in the 5 millimeter zone, and again in the 6 millimeter zone also from 3.43 to about 0.350. So patients are symptomatically much better with less comatic aberrations, and so they're very happy. This is Shady Awad's cornealanalysis.com. It's a beautiful website, and I'll recommend you to go and visit it, where you can do a lot of, you can do all these measurements and a lot of calculations using this website, and it can really help you in your planning. This was our original paper, which we published in the Journal of Refractive Surgery, where it made the cover page. We've also used it in a good number of post-classic ectasia patients now, and here's one example. Here we've used a customized CARES, and basically the only thing that you have to be careful about is where you're going to place your CARES channel. So you can calculate that based on the anti-segment OCT and check the flap depth, and depending on that you plan your placement of the CARES channel. And also you should also, if you're combining it with cross-linking, be careful that you do not lift up the flap when you're removing the epithelium. So that's also giving us, as you can see, very good results from a lot of inferior steepening. We've got almost a very good centralized keratometric improvement with a flattening below and a compensatory steepening above, both of which give you this beautiful regularization that you're seeing here. So I think just to kind of come to the end of my talk, CARES is really a very superior alternative to DALC. And why would I do CARES in advanced cases? Because you can combine it with thin cornea cross-linking techniques. My personal favorite is a contact lens assisted cross-linking, but there are lots of other different techniques. And if you've got one that you like, you could do that with CARES. And though PK and DALC do provide satisfactory outcomes, sight-threatening complications can occur. DALC is a beautiful technique, but it does have a much more steeper learning curve, and you can have complications, intraoperative, postoperative, and the learning curve with CARES is really very very simple. It's a much easier surgery to do, and the postoperative period is also much more smoother. You can just have steroids for just about 4 to 6 weeks, and the patient really does extremely well. And the biggest advantage is it doesn't take away the ability to perform a DALC at a future stage. So you can still perform a DALC if you feel that you want to at a later date, whereas the reverse is not possible. Once you do a DALC, there's no way that you can reverse that and go back. Of course, DALC is also, as I said, can have lots of complications associated. So CAIRS does give you this huge advantage of making it a much more simpler procedure for both the surgeon and the patient. Bioptics, you could combine any of these, topo-guided PRK, phakic IOL, refractive lens exchange, conductive keratoplasty, or any of these with CAIRS. And so you can improve the effect further. It's reversible and adjustable, as I said. Unlike DALC, which is irreversible, and here you can see we did this CAIRS removal for this patient, and it really does come out easily. So this was that CAIRS segment that you saw come out easily, because we did not get the kind of effect that we hoped to, and our planning was not perfect in this case. So here's a patient again where our planning was not great. So we wanted to rotate it in the post-operative period. So it was, you can see the adjustability of CAIRS. You can easily just push it forwards and then rotate it. It's just like a desec lenticule. You do have a little bit of fibrosis at the edges, a little bit of more stronger adhesion at the edges, but ultimately you are able to, with some amount of effort, make it, move in its channel within the cornea. Of course, it would not move on its own, for example, by patient rubbing, but you would actually have to use physical force to move it forwards. This is a patient who progressed post-CAIRS. She came back after 1 year because of the pandemic. She was completely lost to follow-up, a young girl who continued eye rubbing. And I'm showing this video to show you that DALC can also be easily performed after CAIRS. So here's, I wanted to see, this is a 1 year post-CAIRS, so I want to see the difficulty in being able to remove the segment. So as I said, there's some fibrosis or some greater adherence to the edges of the CAIRS. But once you release that, just like removing a failed desec lenticule, you can easily, you can easily just pull out the CAIRS segment. So I'm just releasing all the adhesions, and there you see it can easily be pulled out. And on the other side, the CAIRS, I wanted to let it be there to see whether it would interfere with my DALC. So I didn't explant the second one. And here you can see I've got the trephination, and I actually got a beautiful big bubble. So really nothing gone with the way you do your surgery. It remains exactly the same. So there's the air being injected and a perfect big bubble being formed. You can go ahead and complete your DALC surgery the way you would normally do. And here's the DALC. The first post-operative day, and we also sent that CAIRS for light microscopy, and we saw that that there was absolutely stratified squamous epithelium, the part which the DALC was given, and the other part was a fibrocollagenous stroma only, with no evidence of inflammation or edema seen, which was very good. Our experience with segment change change in segment thickness with time has been good. We've not done a full-blown study on this, but some of the patients whom we've analyzed, we've seen it to remain stable over time, and we're not sure why this is, but it has been seen to remain stable. And this also mirrors Mario Nubile's study with SLAC, where he also says that it remains stable. Is it because of the intrastromal location? Possibly, but also I think most of our cases are combined with cross-linking, so that may also have something to do with it. A lot of other advantages as compared to other additive keratoplasty techniques, which also go over the visual axis, for example, smile lenticle implantation and so on. CAIRS does not cross the visual axis at all. It is untouched. So you do not have any opacification, haze, loss of contrast sensitivity, or anything that could interfere in the long run. There's no glare. CAIRS is in the mid periphery. It's cosmetically good looking. You cannot make out when the patient, when you look at him as you see him. And that basically comes to the end of my presentation. Just to conclude, this is the use of allogenic tissue with no disadvantages of synthetic tissue. It's biocompatible with good corneal integration, less complications. It's easily available, at least for us, and also in many other countries, though in some countries it may not be easily available. It's easy to perform with a pull-through or push-in technique, and also for us it's economical, but maybe not so in every country. It's effective, stable, simple, safe, reversible, adjustable. And also, this is one question which I'm always asked: what about rejection? In our experience, has been a very low level of rejection. But this is possibly because of multiple reasons. The volume of stromal transfer is really low. We know that in DALC itself, the amount of stromal transfer is much more, but even in DALC, the risk of rejection is really low. So with CAIRS, with a much lesser volume of transfer, the risk of rejection is even much lower. Also remember, there's no epithelial or endothelial transfer at all. And because the CAIRS is right within the stroma, ensconced by the patient stroma from all sides, you get very rapid keratocyte repopulation from the surrounding host stroma. It's placed far from the limbus and the limbal blood vessels, so there's nothing there to incite neovascularization. And the host stroma above and below isolates it from tears and aqueous humor that contain high immune factor concentration. For all these reasons, it's really very low level of rejection. And we've had very good outcome with all our patients. We are now at more than 400 patients, but around the world the number is much more, because many other centers have now started becoming large volume centers, and we are all in touch with each other. So with that, I'll come to the end of my presentation. Thank you so much, and I'm really happy to take any questions or anything else that you'd like me to.
Thank you very much, Soosan, for this very nice presentation, and congratulations for this amazing innovation. Actually, it has changed the way of approaching keratoconus in total. And now, of course, I'll open the discussion, and I will start with my question that I think now we can do it for children even, because whenever we face keratoconus case in children, we hesitate a lot to implant the synthetic intracorneal ring segments, because for rubbing, for many reasons. But I think it's not the case with the CAIRS. We can implant it in children very safely. Am I right?
Yes, absolutely. You're absolutely right, Professor Sanjab. This is actually a big advantage. Again, we've done a series of about 10 to 12 children where we've implanted. Our youngest was 8 years. They're able to cooperate reasonably well for the femtosecond laser channel. If the one very simple test that I do in the OPD is you just go to the child and just touch the bare conjunctiva with your finger, and the child who doesn't flinch back or who's kind of not nervous about it, generally they're able to cooperate under local anesthesia or under topical anesthesia. But if you do see the child being a little scared, you can ask your anesthetist to be there anyway and give a little amount of sedation, and you're able to make the channel easily. And these patients really do well because you're able to get flattening of the, and we know that children are much more aggressive in nature, the keratoconus. So you're able to get good flattening, combining it with the cross-linking. You of course do need to tell the parents that they have to still be on the lookout for progression beyond the frequent follow-ups. Now youngest is 8, and we've got a good, I think we've got a good pediatric series now, and actually we should be looking at publishing it now.
Very interesting. Thank you very much. Dr. Hussam.
Yes, sir. Thank you, Professor Mazen Sanjab, for having me in this prestigious academy, and to the Wonderland. Thank you, Dr. Soosan, for great presentation, and you are wonderful as usual. You know that I'm following you since a long time with your talent and your great ideas about this field. I would like first to assure you that I'm still having your dissector. You asked me about what I have, and I will show you now this dissector, which is handmade dissector. It's actually made just for you on your request. This dissector for the CAIRS. It's not for the usual or the traditional intracorneal ring segment. This dissector is broader and bigger, with bigger size than the other one. Its width around 2 millimeter, and with an inner diameter of 5.5 and outer diameter of 7.5, and it's bidirectional for both sides. So I'm still keeping it for you. Don't worry about it.
Thank you so much. I'm looking forward to getting that in my hands and using it.
It's my pleasure. But my question here, the same parameters for CAIRS. I'm asking about the parameters for CAIRS. The same for the traditional or the synthetic one, about the depth?
No, actually, it's quite different. When we started out, we kind of used the same parameters, but then we realized very quickly that the parameter, you can actually make use of or take advantage of CAIRS to be able to change the parameters to your advantage even further. So we've gone much more superficially. So we go at around 50% of stromal depth now. So 50% of the stromal thickness, that is at the minimum zone of implantation. So that's what we do. And so we are much more superficial, and we get a stronger effect, I think, because of that. And also we are at a smaller optic zone. And because there's no glare or halos like synthetic segments, again, we are able to get more effect than if we had used a larger optic zone.
Okay, so you think the shallower depth will be more effective than the deeper one in such cases?
Yes, because
The-
CAIRS does not act exactly in the same way as Intax. Intax has an
Yeah.
arc shortening effect, which means it's pulling it apart and thereby
Yeah.
flattening central cornea. So CAIRS actually works not just by that. I think the major mechanism of CAIRS is by volume augmentation. So you're putting tissue there and you're augmenting the volume, which makes the cornea flatter there. And at the same time, because sometimes you do put larger segments, you do have some amount of arc shortening as well. And I think the third
Yeah.
mechanism that it acts by is also epithelial remodeling. So because it's more superficial, you get more amount of epithelial remodeling than you would with an Intax or a synthetic segment. So I think these are the three mechanisms that it acts by.
So what about the results on using the nomograms? You have your own nomogram in calculation of the length, the arc length, or the thickness?
Yeah,
Or what?
yes, we have kind of come to a stage where we are able to predict to some reasonable extent about how much result we are going to get. We definitely know that we are going to get that when we put a segment here, we are going to get flattening here, and this is the area where we'll probably get some steepening. But we are still not able to predict exactly to a diopter. So it's still not anything like refractive surgery where you can tell the patient that yes, we are going to make you free of glasses. We've still not reached that stage, and I'm not sure if in keratoconus you can ever reach that stage because it's a completely different disease. You might have the same tissue implanted in two different patients, and just because their biomechanics are different, you'll get different amounts of result. So to some extent, yes, we have nomograms where we are able to tell the patient, we'll definitely be able to improve you. We'll be able to improve your uncorrected. We'll be able to improve your best corrected. We'll be able to bring down your power. But I don't think we can realistically tell them that we're going to be able to make you glass free.
Yeah, okay, but in patients with high degrees of myopia, do you consider the concept of doing a pocket or a tunnel-like pocket to put to put a complete ring all around? It will flatten the cornea more and treat the myopia in conjunction with the flattening of the corneal surface?
We have done that. We put about very close to 360, 330, 350 degree segments. We put actually one of the patients which I showed, who had about a 35 diopters of flattening was one long thick segment which was going almost all around. So that does work quite well to give you flattening. I think Jack has also done many patients there with advanced flattening where he's able to bring it down quite a bit and give them a lot of reduction. So yes, you can bring about quite significant amounts of decrease in the sphere just by pure flattening of the cornea alone.
Yeah, okay. Do you consider the high order operations before going to do it? You're aiming at correction of the high order aberration by certain or special figures?
Not by not by the amount of microns of correction or things like that. But yes, if we see more coma than astigmatism, we may aim at correcting coma more, which means we may think of putting a single segment instead of symmetric segments on both sides. But if we see the astigmatism is more than the coma, then we would put two segments on either side, which would help in correcting the astigmatism more. So that is how we do it. But again, as I said, you cannot precisely get it to the level of exactly getting rid of such and such amount of coma or such and such amount of cylinder.
Yeah, so this my call now to work on it in the coming days to study the changes or the correction of the high order operations regarding this CAIRS. I think the thickness or the width of the CAIRS segment itself will be customizable if we consider the high order operation correction in such cases. So the last question about this point will be, did you have rejection in such a CAIRS before?
So no, CAIRS patients have not really come back with rejection. Again, me and Jack, this was about, I think, at least more than maybe close to a year back. We had submitted a combined paper where we had one case of rejection in all our cases together. At that time, I think we had a total case number of about 280 patients or something. And we had one case of rejection where the patient came back with a red eye and some amount of superficial vascularization. It was recognized as a rejection, and this was in Jack Center actually, and he started steroids immediately, and the patient had very good recovery. So at that point of time, with our combined case series, we calculated I think a risk of rejection of 0.5% or something. But now we have a larger series together. I'm at 400. I think Jack is also at a very good number. So that rate of rejection would have come down further because we're still at that one patient.
Yeah, okay, but I think because you are removing the epithelium and the endothelium, the rate of rejection will be almost rare or none.
It is very
actually, but if you have like this case, how to differentiate the rejection from the infection from the reaction around the tunnel? There is a special sign for that.
So I think rejection would, not probably be immediate. It would be a little more delayed presentation. The patient would have some amount of swelling, some amount, not swelling, I mean some amount of redness, and maybe you might see some cells or something. Those are probably the typical signs that you would look for in case of corneal rejection. That's probably what you would look for. You would not get the typical, endothelial signs or the KPs that crawl across the cornea, like the Quadratus line and things like that. Those I don't expect to see. What I would probably expect to see is just minimal redness and some amount of cells, but that's really rare. And as I said, even in the worst case scenario, if it rejects also, it doesn't matter. You're not looking for clarity in this tissue. This tissue is in the mid periphery, it's away from the visual axis, and unlike a corneal transplantation, which when it rejects, it loses its clarity and therefore vision is affected, here it doesn't matter. You wanted only volume expansion with that amount of tissue. So whether it is opaque or transparent doesn't matter. And even if it does, some tissues do gray out with time. They don't remain completely optically clear. Many remain completely optically clear. Even the ones that become a little gray out with time, they're not seen when you look at the patient. You cannot see them. So cosmetically, you cannot make out unless you're looking at the patient with the slit lamp. So that really ultimately has no effect on whatsoever on the patient's visual outcomes at all.
Yeah, but in such case, you will go to remove the segment or to deal with like the corneal rejection.
What I would do just exactly what Jack did: give a short course of steroids, do a slow taper, and then that's it. That would probably be my answer. That would be my only answer. I wouldn't want to remove it at all because I don't think there's any need to remove it.
Yeah. Okay. Thank you. But finally, I will ask a technical question. We have to do 2 incisions to be enabled to pull the segment, right? There is no instrument to help to catch the segment from one pull to rotate around.
Yeah, I do have actually an instrument which I call as a pigtail probe, which is very much like your lacrimal duct, the pigtail probe that you use for lacrimal tears, which is just as a round. It goes like a pigtail, and you can thread it in from one side and pull it out from the other, and then you can tie it or do something like that with the CAIRS segment, and you can just rotate it back. And I'd also like to say that Shady Award from Lebanon has just also designed an instrument, which is a very, very interesting instrument for doing precisely this, where you have just a single incision and you can just pull that entire CAIRS back into the channel. So these are now, of course, with more people doing this technique, new ideas are going to come out, new instruments are going to come out, and that's exactly what I see happening. The other thing that I want to say is that intralace, for example, allows you only one incision, whereas the Visumax, which I use, allows you 2 incisions. So when you have only one incision, or let's say that even though I have a Visumax, I want to put only one incision simply because my CAIRS is longer than 180 degrees. And so I don't want the incision over it. So in that case, which means I don't want incisions exactly opposite each other. Let's say I want it at an angle. In those cases, I put only one incision. And the second incision, what I do is I take a sharp blade, and just make a small cut right over the gas bubbles. From the femtosecond laser. And the minute you see the gas bubble escaping out through that incision, you know you are in the right plane. And that can be used as your second incision to
like in the manual technique, right?
Like in the manual technique.
Okay. I was thinking a lot about this point, and I was talking to my engineer who made this instrument to think about a solution for that. Thank you very much for your great innovation and your wonderful presentation about that. It will open the door. It will actually open the door for a lot of thoughts for the corneal inlays and treatment of the many corneal problems and refractive surgeries as well. Thank you very much.
Hussein. Now, just 4 questions. We don't want to take too much time from you, Prof. Soosan. The first question is your approach different for pellucid marginal degeneration in comparison with the keratoconus? Because there is inferior thinning. What do you think?
Yes, I use a slightly different approach with PMD. But right before that, I'd like to just state that I have not done too many cases of PMD because obviously the condition is much more rarer than keratoconus. So I have done some patients, and I use a slightly different approach where I basically put two thinner and shorter segments on the steep axis just to lift it up, and we've got good results. I sometimes combine it with an incision in the the flatter area just to suture it and make it steep. But this is all just, I'm just trying this out, so I don't really want to tell anyone that this is a better technique or anything till I am myself uncertain about it. My friend David Gunn from Australia, who's also treating who's also doing a large number of CAIRS, he uses a slightly different technique for PMD, where he does the conventional one which you do for intacts, where you put one underneath that. So there are different ways, I think, but I think we just need to do a larger series, around the world to know which works best.
Great. A question from one of the audience that what other refractive procedures we can do in patients with CAIRS?
Yeah, that's a great question. In Canada, Greg Maloney and some other very senior doctors like Dr. Alan Slomovich and all, they're also going to start CAIRS, and they have been considering, Greg especially has been considering combining topo-guided PRK with CAIRS. So is Tanya Trin from Australia, who's also going to start topo-guided PRK with CAIRS. I think Shady Awad is already doing that. So you can combine all of that. It would basically be your preference. What have you been doing with ICRS so far? What are you comfortable with? So if you are comfortable doing topo-guided PRK, then you can definitely go ahead and do that. Phakic IOL is another great option, and that's really nice because sometimes patients with irregular astigmatism, you can actually make it more regular using CAIRS and then put in a phakic IOL, which will give you much better effects than directly having put a phakic IOL. You can combine it with refractive lens exchange. You can combine it with just conductive keratoplasty, though it's not being done much around the world at all. You could possibly do that if anyone still has that machine. So there's nothing to stop you from combining it with anything actually. But if you're combining it with intraocular lens, of course, you would have to figure out the intraocular lens power calculations, which is always difficult in a patient with keratoconus. But that's again something which we've been doing. We've got the IOL pre-op IOL master for many of our patients, and probably we should be looking at how it changes post-operatively after CAIRS implantation.
How long do you wait for the stability of the cornea until you can do the topography guided treatment? For example, you wait 3 months, 6 months?
I personally have not done any topography PRK combined with CAIRS. I haven't done it just because I'm a little more conservative and I'm a little wimp as far as that is concerned. But I would love to start doing it maybe sometime. Not yet. But probably the stability, I would say, would be around, for me, stability in terms of when I prescribe glasses is around 2 months. Temporary glasses, and then what I tell them is over time you'll have to change your glasses a few times again. I'm not sure how topo-guided PRK surgeons who are doing that would want to do that, so I'm not really the right person to answer that question.
Thank you very much. Now another question, whether we have to do corneal cross-linking with CAIRS in ages older than 30 years.
So yeah, whether it should be combined with CAIRS or not, with cross-linking or not, would just depend on whether the patient you think is progressive or not. So if you think it's progressive, it's always better to combine with cross-linking. If you think it's non-progressive, then you don't necessarily need to. So your decision will be based on that. Also, some people prefer to do CAIRS, wait for some time and then do a cross-linking. I prefer to do it simultaneously because I like to finish my surgical procedures together. So I have always done that with synthetic segments also, and I continue to do that.
So there is no loss of effect because with CAIRS, because we know very well that in the intracorneal segments, a huge number of patients may lose the effect within months. So even after 30, we may go for cross-linking as well, just to secure the effect. So it is not the case with the CAIRS.
Again, that's a beautiful thought, Dr. Sinjab, and I think that may be true. But 99, about 95, 95, we've done about, I just went through this data about a few days back because someone from UK wanted to do a study on this topic. So we've done about 400 plus cases of CAIRS with cross-linking, but the pure CAIRS alone has been only 12 so far without cross-linking. So it's too early for me to say that number is too small for me to be able to really say what is happening there. And some of them are just very recently done. In fact, one patient just got both eyes done. So our CAIRS with cross-linking patients do very well. The stability continues to remain well. The segment thickness also doesn't change much for the limited studies that we've done. It continues to remain the same, which is really very encouraging. And when people ask me why the segment thickness is remaining the same, I say generally what I've attributed to is that the cross-linking fixes it in place. It kind of firms up that tissue so that it doesn't keep on thinning out. So I think what you say definitely has a point, that maybe with time you may lose an effect with ICR with CAIRS if you don't combine it with cross-linking. But most of our patients are, fortunately, now that you say this, automatically cross-linked by us.
Yeah, very good. Okay, I think the last question is what are the measurements of the double-bladed trifine, double-blade trifine?
Yeah. So we've currently got it in two measurements, which is inner diameter of 6.5, outer diameter of 8 millimeters. And then there's another one, which is 7.75 and 8.75. But I do want to tell you that that this is not corresponding to the channel size. So our most frequently used one is a 6.58, and we don't have to put it into a 6.58 channel. The channel can be much smaller. So we put it generally into a 4.5 millimeter optic zone channel, because this just changes. It's soft tissue. It's not like Intacs where you have to have the same optic zone. So this is soft tissue, so you can just use any size of optic zone. You could also get smaller segments if you cut it linearly across, but generally we find that these two are all that we require in most patients.
Okay, great. Thank you very much. We enjoyed very much. Yeah, please.
Dr. Mazen, Dr. Soosan, I would like to ask about the remaining part of the corneal button after having the central corneal graft. This remaining button will be suitable for CAIRS. You know that we have a problem in having the corneal grafts. So if I used the corneal graft, the corneal donor graft for a case of PKP or DALT, and the remaining part of the corneal tissue with the sclera, can I have the CAIRS from this part, the peripheral part of the cornea?
So if you could use the larger segment, the 7.75, 8.75 for that. And if we find more surgeons wanting to start using this, then we could change the size of our trifine to correspondingly accommodate this also. Yeah. So we could start manufacturing one more size of trifine which would accommodate this also. Currently, the 7.75 does allow you to do that. And you could theoretically cut the CAIRS first, not remove the endothelium, cut the CAIRS first, take out the central cornea and use it for a PK. If you're doing a DALC, remove the desmoids, use it for a PK. You could use the limbal stem cells for limbal stem cell transplantation. So yes, you could use the same cornea for multiple things.
Okay, thank you very much.
Okay, great. So we came to the end of the session, and actually we enjoyed a lot, and we know that if we stay with you more time, we'll learn more, but we don't want to overload your full program. Thank you very much, Professor Jacob, for your precious time that you gave us and for being with us. Thank you as well, Professor Hussam. I'd like to thank the audience for being with us as well. And have a good day, the rest of the day for everyone.
Thank you so much.
Thank you very much. I'm glad to see you, Soosan. Bye-bye.
Thank you. Thank you so much.
See you. Bye-bye. Bye-bye.